and this recording will be posted on our website by tomorrow. To get us started, let me introduce you to Dr. James Karinji, who will be introducing our speaker for today. Jim, the floor is yours.
Thank you so much, Patrick, and thank you, Patrick, for all you do to make this happen every week. It's no small task. So welcome, everybody. I'm Jim Karinji from the School of Public and Community Health Sciences. It's great to see you all. We are lucky to have a speaker today, and Mari Hodges, who will be talking about healthy notions of pain and what to do, what it all has to do with public health. This is something that is super important, that cuts across so many areas of public health. So Mari, thank you for joining us today. I want to again ask folks to, I know sometimes folks have to turn off their camera. It's more comfortable during the presentation. Do whatever you do to need to be comfortable. But at the end, when Mari will be taking questions, if you are comfortable turning on your camera, we're trying to build as much of a sense of community as we can. And also Mari has asked that we keep questions to the end. And if you're like me and you forget things and you want to put those questions in the chat right away, please feel free to do so. So again, thank you so much for joining us, Mari.
Thank you, Jim. Is my sound okay? All right, thank you. I'm very excited to be speaking with this group of people passionate about improving the health of individuals and the community, experts in public health, advocates for people with pain, and perhaps people with lived experience of pain who are also experts. My name is Mari Hodges. I hold a Master in Science and Medicine in Pain Management and a Therapeutic Pain Specialist certificate. I'm a teacher of the Alexander Technique, which is an embodied mindfulness practice, and I'm a person with a lived experience of pain from which I've happily recovered. Today, I'd like to talk about persistent pain as a public health issue, what the current scientific understanding of pain is, some barriers to evidence-based treatment for pain, and some more useful ways of thinking about and addressing the problem of persistent pain. There's a lot that we still don't know, but we do know that a modern understanding of pain can help individuals with their recoveries and to find improved ways of addressing persistent pain on a societal level. What I'm going to talk about today may be familiar to you, and many of you may know firsthand just how difficult it is to treat persistent pain. But despite the increasing number of interventions, no single intervention has had a large effect for a large group of people for a long period of time, and rates of chronic pain continue to rise. Because of the narrative around pain, there's a tendency to seek out non-evidence-based treatments. But we can direct people toward more effective treatments by changing the narrative with healthier notions of pain based on a current scientific understanding. Understanding what drives pain can help us to better manage pain on an individual and a population level. 1 in 5 Americans experiences persistent pain, with estimates up to 40%. 8% experience high impact pain that frequently limits life and work activities. And pain is the greatest single reason for seeking out healthcare. Persistent pain is a massive problem. The incidence is high compared with other quantified chronic diseases and conditions, such as diabetes, depression, and hypertension. Chronic pain conditions are among the highest causes of years lived with disability, a measure of the impact of conditions on individuals that includes prevalence and severity. And in the global burden of disease, many, though not all, pain conditions are grouped into musculoskeletal disorders, though many other conditions also include pain and contribute to pain. The single most burdensome health issue in the country, the greatest cause of years lived with disability, is chronic back pain, with other pain conditions in the top 5. Persistent pain can occur as the result of an injury or disease, but the International Classification of Disease now includes chronic pain as a disease in its own right. The new ICD-11 classification distinguishes between acute and chronic pain. It reflects a biopsychosocial model of pain, which I'm going to talk about. and it clarifies and provides previously non-existing diagnoses. And this helps to make the prevalence of chronic pain more visible, promoting a better estimation of the burden of persistent pain, better access to treatment, and prioritization of resource allocation. Persistent pain is more common among women than men. It's more common among people who are unemployed, who are living at or near the poverty level, or who are undomiciled, who are living in rural areas, who are older, and who have a lower educational attainment. These socioeconomic and environmental factors are also drivers of pain and pain-related disability. Persistent pain disproportionately impacts marginalized and disadvantaged communities, and people of ethnic and racial minorities are less likely to receive effective pain treatment. Pain takes an enormous toll on individuals and their families, and the societal economic cost is comparable to other health conditions that are more well known, such as heart disease, diabetes, and cancer. And it's thought that the burden of persistent pain will continue to rise with the increase in America's aging population, inactivity, and obesity. But even with these dire statistics, let's start with some healthy notions, meaning ways of looking at the problem that are objective, useful, and hopeful. And the first I'd like to propose are that persistent pain is common and it can affect anyone, but disadvantaged communities are disproportionately affected. If we are to help the populations most in need of pain-related public health initiatives, we must take a health equity perspective and consider social determinants of health, because these are also drivers of pain. And if we do so, it's possible to make individuals and society more resilient. And I hope to finish with some ideas about how to do that. But what are we doing now about pain? Conventional approaches such as imaging, surgery, medications, injections, nerve ablations, and other passive therapies are widely used, often in the search of an elusive biological origin of pain that in many cases can't be found. But let's look at some of these. Excessive rest and passive coping lead to poor outcomes. Just telling people to stretch and exercise isn't working. People with severe pain often find exercise difficult, and many people are not willing to exercise precisely because it hurts when they move. Many medications come with harmful effects. Opioids, for example, may be useful for some people in some situations, but they can also promote dependence and, ironically, more pain in a condition known as opioid-induced hyperalgesia. A one-size-fits-all passive therapy approach as a standalone intervention likely provides no effectiveness over any other intervention except some short-term relief. In many cases, these approaches lack evidence of effectiveness, and they're often accompanied by risks or adverse effects that outweigh their benefits. They promote increased healthcare utilization and lead to poor outcomes. Conservative treatment and medical interventions have failed to resolve the problem of persistent pain. They're just not that efficacious in and of themselves. Here are some examples of the lack of evidence of effectiveness of some typical medical practices for persistent pain. Inappropriate lumbar spine imaging leads to poor outcomes and increased healthcare costs. Surgery for lumbar disc herniation provides no benefit over conservative treatment, and we've seen that conservative treatment isn't helping either. 35% of patients continue to use opioids long-term after lumbar spine fusion. But there is real hope of turning things around because of the revolution in pain science in the last decades. And there are newer approaches based on this revolution in pain science that are showing greater effectiveness for persistent pain. And I'm going to tell you about them and why they are working better. But first, why aren't conventional therapies working? because they're based on the assumption that the problem is in the tissues. Well, it is, right? If you have pain in a body part, it means there's a problem in the body part, right? If your body hurts, it's because you've injured yourself, you've damaged something, or something hasn't healed, right? End of story. Well, it's actually not quite so straightforward as that. Many investigations and interventions are based on the assumption that pain is an accurate indicator of the state of the tissues, and that resolving the underlying pathology will resolve the pain problem. Total knee replacement is an example of this. The assumption is that if you remove the painful joint, the person will no longer have knee pain. And actually, 20% of people who get total knee replacement continue to have chronic knee pain. These assumptions can be termed a biomedical model, and it's now known that a biomedical model for pain is overly simplistic and limited in its usefulness for understanding and addressing pain. To understand why that is and why these approaches aren't working, we need to have a good understanding of what pain is and how it works. Modern science shows us that there is a weak relationship between tissue damage and pain. That pain is not an accurate indicator of what is going on in the tissues. And that pain is a sensory and emotional experience influenced by context and meaning, requiring more comprehensive approaches. Pain depends on context. I want to tell you the story of a woman who was involved in a car accident to give you an idea of the importance of context. But first, some context about whiplash. Whiplash refers to the strain and pain that occurs from a rapid forward and back movement of the head and neck. And whiplash from a motor vehicle accident usually resolves in a short period of time. But up to 50% of people continue to have symptoms. Some people develop pain and disability, often severe, for years. And many of these people are involved in litigation around the accident. Whiplash-associated disorder, or WAD, is a chronic condition involving neck pain and stiffness, muscle spasm, dizziness, headache, malaise, often in the absence of any evidence of structural pathology. The pathophysiology of whiplash-associated disorder is not well understood, but it is known that the risk of developing it is influenced not only by the severity of the impact and the initial pain, but by poor expectations of recovery, post-traumatic stress symptoms, and passive coping. And these last three are the most consistent predictors of chronic neck pain and disability after a whiplash injury. The story is about a long-term Alexander Technique student of mine, to whom, throughout my studies of pain, I have told about all the fascinating things that I was learning about pain, including the weak relationship between tissue damage and pain, things that can trigger pain, how pain works. And not long ago, she was involved in a car accident. She was hit from behind, she whiplashed, and the car was damaged. She called me to have a session to calm herself and to reorganize herself. She wasn't badly injured. She did have soreness in her neck. And after that, she left on a planned vacation for 2 weeks. When she returned, she noticed that most of the time she was fine, but when she was driving by that same spot where the accident occurred, she felt pain in her neck. And she realized that the location was triggering a memory of the accident and the pain. And she was curious about this. She was fascinated by it. She didn't freak out, and her pain didn't worsen. She did notice that she was worried about the car situation, and that was associated with some stress, and that was associated with some neck soreness. And luckily, the car situation also resolved, and the happy ending is that she recovered well. But she also realized that the situation could have been very different based on her own reactions and thinking. And it's fascinating to see how her understanding influenced her experience. Here's a fun fact about whiplash. In the sport of demolition derby, there are no rules except that you're not allowed to crash into the driver's side door. And demolition derby drivers sign an injury waiver that they accept all legal liability for their own safety. They accept the dangers involved in the event. And they're out there crashing into one another, having fun. A study investigating whiplash-associated disorder found that 90% of demolition derby drivers experience no chronic neck pain, despite the high number of rear-end collisions that they are involved in. And their average pain episodes were less than 3 weeks. We can see that context matters. To understand what pain is, it helps to know what it isn't. Have you ever discovered a bruise or a cut on your body and you didn't know how it got there? You didn't notice when it happened because it didn't hurt? Maybe while playing sports. Or have you ever gotten up during the night to go to the bathroom in the dark and stubbed your toe and it hurt like the dickens, but nothing really happened to your toe? There's rarely a one-to-one relationship between pain and tissue damage. And when pain persists, that relationship becomes more tenuous. Research also shows that the amount of tissue damage does not predict pain severity. In some conditions like chronic back pain, fibromyalgia, chronic regional pain syndrome, some kinds of headache, severe pain may occur without any identifiable tissue damage. And people with significant spinal abnormalities, such as disc degeneration or disc herniation, are often pain-free. People with rotator cuff tears, people with osteoarthritis, are often pain-free. The image here on the left shows the spine of a pain-free person with a disc herniation. These other images have some interesting stories and some interesting pain experiences involved. The picture of the boot with the nail through it is of the case of a construction worker who accidentally jumped down on a nail that pierced his boot. And the man was in severe pain, but when they cut his boot away, they found that the nail had actually passed through his toes and hadn't even pierced his skin. And the man's excruciating pain was influenced by his perception of what had happened. The picture of the skull with the nail in it is also the case of a construction worker who accidentally shot himself in the jaw with a nail gun, and he didn't realize it. This X-ray was taken by his dentist sometime later when the man went in for a toothache. So we can see that meaning and context matter and they affect perception. So pain is not a marker of structural pathology. Here are some interesting examples. 97% of people with no knee pain have structural abnormalities in their knees. 84% of people 48 years old with no back pain have disc degeneration. And the severity of rotator cuff tears is not correlated with pain severity. So these statistics tell us that pain is about something more than tissue damage. The tissue damage doesn't tell us the whole story. So what is pain? First, it's important to say that all pain is real, no matter what the cause, no matter if a cause cannot be found, no matter if the pain is in a body part that isn't even there. Pain is a protective response of a pain system to actual or potential damage, to actual potential danger of damage. Pain grabs our attention. It keeps us from harm. It keeps us from exceeding tissue tolerances, for example. Has anyone here ever touched a hot burner or something else burning hot? It's likely that pain motivated you to pull your hand away before your skin was damaged. Pain usually protects us from injury. It acts as a safeguard to keep us safe. It warns us about danger, like the proximity sensor on a car that beeps as you're backing up and approaching a pole, for example. It starts to beep, 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 beep. As the car gets closer to the pole, the beeping speeds up. Beep, 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 beep. If we ignore the beeping, we may hit the pole and damage the car. And pain is the same. It's telling us about danger. And if we don't heed the message, we may damage our body. When injury does occur, the pain system provides extra protection with extra sensitivity. Sensitivity refers to a decreased pain threshold or an increased response to stimuli and a heightened perception of pain. An example is a sunburn. Has anyone here ever gotten a sunburn? If so, you've probably noticed that even light touch or your normal shower feels painful despite any lack of harm. Sensitivity promotes healing after an injury because now minor things hurt. It motivates us to change our behavior, to reduce movement, or to protect a painful body part. And I can speak to that with a recent broken elbow. So pain system sensitivity has an evolutionary benefit. It helps us to survive. And as tissues heal, usually that sensitivity goes back to a normal level so we can get back to movement and tissue recovery. But sometimes, and for some people, pain persists longer than expected. Even after tissues have healed, pain can persist. This hypersensitivity manifests as increased pain with harmful or noxious stimuli, or pain evoked by non-noxious stimuli. So pain system hypersensitivity keeps us from doing things that would make us better. It becomes overly protective. Pain system hypersensitivity is like the car beeping fast and soon and often, even though we're not even close to the pole. It's a problem with the system. And pain system hypersensitivity is an overly protective response of a sensitized pain system. And when the system becomes overly protective, it's no longer accurately telling us about potential danger. And persistent pain is the same. It's telling us about danger when there isn't necessarily. Sustained changes throughout the nervous system can occur and perpetuate pain, even without any evidence of tissue damage. These changes can worsen over time, so the longer that you have pain, the more sensitized the system becomes. Various parts of the nervous system adapt to protect more, and chronic pain can become a disease in itself. How do you know if you have a hypersensitive pain system? Well, pain tends to be disproportionate to the injury or future injuries. It tends to be throughout the body in different sites. It lasts longer than the healing period of tissues. You may have sleep, mood, or memory problems. You may have an altered sense of your body, where you don't feel stuff the same. Maybe your body doesn't move the same, it moves differently. You might feel extra tired, and medications just don't seem to help. To summarize this information about pain with some healthy notions, all pain is real. We can't necessarily see it. Imaging that doesn't show any structural pathology doesn't mean there isn't any pain. And structural changes that we can see on imaging aren't necessarily related to the pain. increased sensitivity of the pain system may be driving the pain experience. Also, pain protects and promotes recovery. It helps us to recover, but persistent pain overprotects and it gets in the way of recovery. So what makes the car beeper settings more or less sensitive? What makes us more or less sensitive? Well, many factors contribute to influence how often and how quickly and how soon the car beeps. Many factors influence pain to turn it up or down. Every time and for every person, pain is a unique individual experience that's influenced by a unique combination of interacting biological, psychological, and social factors. So that includes physical sensations, as well as emotions, thoughts, behaviors, and the social environment. Pain system sensitivity changes depending on what's going on in your life or what's gone on in your life in the past. The biopsychosocial model is now established as a more efficacious way of understanding and addressing pain. It tells us that it's not just biological factors, but also emotional, cognitive, attentional, behavioral, social, and environmental factors that interact to create the context for pain, to drive it or to reduce it. And here are some examples of things that can influence pain: general health and fitness, sleep, activity, stress, past experiences, a pandemic, fears, things that we do to cope, beliefs, relationships, diet, emotions, and the social determinants of health. Here are some more examples, and I invite you to reflect on whether any of these may have ever influenced a pain experience of yours. Pain can be classified according to its mechanism, and there are three types. Nociception refers to activity in neural pathways as a result of actual or potentially damaging stimuli or inflammation. It typically occurs as a result of injury, surgery, reduced blood flow, or stretch of organs. Neuropathic pain refers to damage or disease of the somatosensory nervous system, the part of the nervous system that contributes to feeling. Changes occur to the structure and the function of nerves such that pain can occur spontaneously without any other tissue damage. And responses to stimuli are magnified. Both nociceptive pain and neuropathic pain can contribute to a hypersensitive pain system. Nociplastic pain refers to maladaptive changes in pain processing and modulation in the nervous system without evidence of tissue damage or nerve damage. The term nociplastic was introduced in 2016, and while it's not completely understood, it describes the changes that occur on multiple levels of the nervous system, including increased sensory input to the brain and reduced control of sensory input by the brain, or impaired descending modulation. Some symptoms of nociplastic pain include widespread intense pain and sleep, mood, and memory problems. Some examples of some nociplastic conditions are fibromyalgia, chronic regional pain syndrome, some kinds of headache, temporomandibular joint disorder, and irritable bowel syndrome. Nociplastic pain is a mechanism that's also often involved in chronic back pain and osteoarthritis, as well as other persistent pain conditions. Nociplastic pain generally doesn't respond well to peripherally targeted treatments, such as anti-inflammatories, opioids, injections, or surgeries. One key feature of persistent pain is neuroplasticity, which refers to prolonged changes on multiple levels of the nervous system as the nervous system adapts. One important kind of plasticity that occurs in persistent pain is increased sensitivity and responsiveness of neurons in the back part or the dorsal horn of the spinal cord. So we could think of this as, for example, one arrow coming in from the foot to the spinal cord, and from the spinal cord, 5 arrows going up towards the brain. There's a change in pain processing at the level of the spinal cord. Another type of change that occurs is sensory motor disruption. And the picture here was drawn by a person in a study on chronic back pain. And this person experiences pain in the pink area that you can see in their lower back. And the people were instructed to draw their back, but only the parts that they could find. And this person could not find the area where there are no hard lines. And from this, we can see some evidence of the impaired body awareness that also occurs in persistent pain. And some of the other changes that can occur is just the body feels different, the body moves differently, and there are changes in the distribution of muscle activity throughout the body. In persistent pain, other changes that occur are changes in the brain. There are structural, functional, and connectivity changes, as well as volume changes that occur in persistent pain. The pictures of the brain maps that you can see here are of people in red with phantom limb pain, which is a condition of pain in a limb that no longer exists as cortical reorganization occurs. So physical locations of body representations in the brain shift. Another type of brain change, or another type of nervous system change that occurs in persistent pain is impaired descending modulation. And we can remember those 20% of total knee replacement patients who continued to experience chronic knee pain. Well, it turns out that they have altered pain processing in the nervous system, and temporal summation is one way of measuring that. But neuroplasticity also means that pain can change. And this gives hope, and it also gives us targets for treatment. Although much remains to be learned, it's generally considered that neuroplastic changes are not irreversible, and many studies have shown reversal of many of these changes. The ability of the central nervous system to adapt and change is central to rehabilitation and recovery from persistent pain. So to address pain, we must address the brain. And the message here is that the pain system can become hypersensitive, but over time and with work, we can reduce that sensitivity back down towards a normal level. Here are some recommended treatment components for persistent pain that ideally are part of a multidisciplinary, multimodal type of care based on a biopsychosocial model. I won't read them all to you. There's many interesting ones here that can be helpful, but I want to draw your attention to the pain education. And over 75 clinical trials of pain science education for patients from around the world have shown small to medium effects for pain with movement, worry, fear of movement, self-efficacy, disability, and opioid use for various pain conditions, highlighting the notion that pain education should be frontline treatment for people with persistent pain. A recent meta-analysis also showed that pain education plus exercise provided the most sustainable benefits for people with low back pain. Newer approaches based on a modern understanding of pain science target the central nervous system, including the brain, beliefs, movements, and behaviors, as well as the body. To summarize this information with some healthy notions, many factors influence pain, and there are many ways to reduce pain and promote recovery, and learning about pain is one of those. I'd like to tell you about a few recent promising interventions for chronic back pain. And the first of these is cognitive functional therapy, which has shown strikingly large and sustainable benefits for pain and disability, in contrast with older conventional approaches that typically show short-term benefits but not long-term ones. In CFT, they first identified the unique contributing factors for each person's pain and disability. And then based on this, and these could include movement, posture, cognitions, so thoughts and beliefs, emotions, behavior, and social and lifestyle factors. And based on all of these, they tailored education about pain to the individual so that the individual could make sense of their own pain. Next, the people learned relaxation and self-regulation techniques that they put into practice in behavioral experiments around painful movements. And finally, they received advice and support for lifestyle changes and help incorporating their new learning into their life. And this intervention was designed to actively engage people in their own management and recovery, as opposed to promoting a passive attitude towards treatment, which is typical of a biomedical approach. The other intervention I want to tell you about is sensory motor retraining. And this intervention aims to address the altered pain processing that disrupts sensory motor abilities in persistent pain. And this psychophysical intervention was designed to change how people think about their body and pain, how they process sensory information, and how they move. People first, again, learned about pain. Then they engaged in activities that involved proprioception, body maps in the brain, and active movement. And some examples of this are tactile acuity, as you can see in the picture here, left-right judgments, as can be seen with this hand picture here. Also mental rehearsal of movements, and mirror therapy, which tricks the brain into movement without pain, and gradual progression to movement. And this was done to reestablish non-protective patterns of neural activity and movement. And this rigorous study that controlled for non-specific effects of any intervention showed modest and sustained benefits for low back pain. However, pain still tends to be treated with approaches not based on evidence or guidelines, rather than according to current scientific understanding. Large percentages of patients receive inappropriate referral for imaging, passive therapies that promote healthcare dependence, and surgeries. They often receive recommendations to rest and use pain as a guide, which as a recommendation in principle is inappropriate for people with persistent pain. People receive opioid prescriptions for persistent pain. And they often do not receive pain assessments, pain education, advice, or support for self-management strategies. Effective biopsychosocial-based treatments are often not used, and most patients don't even want them, probably because of widely held misconceptions about how pain works. The stronger the structural pathology beliefs that a person holds, the more likely they are to engage in unhealthy pain behaviors, passive coping strategies, avoidance of activity and work, and greater use of bed rest and non-evidence-based medical practices, leading to poor outcomes. There are barriers to science-based care. First, pain is complex. So we saw it's not straightforward. And identifying the mechanisms and the unique contributors can be challenging in a clinical situation. It takes time and effort to shift a patient's understanding about a complex pain problem. It takes time and skills that are often not available in settings where they're most needed. Additionally, there are many misconceptions about pain among the general public, clinicians, and healthcare organizations. And these misconceptions present a considerable barrier to tackling the problem of persistent pain. Some of these misconceptions include the idea that pain equates to structural pathology, and if not, it's psychosomatic, that you should use pain as a guide, that pain should be investigated with imaging, and that it should be treated primarily with rest, medications, surgeries, and passive therapies. These misconceptions are common due to lack of availability of education on the undergraduate and graduate levels and in the community. Healthcare professionals are often highly trained in acute pain and injury management, often not trained in management of persistent pain. Healthcare professionals receive limited education about pain. In fact, 96% of medical schools in the United States have no compulsory pain education. And without a contemporary understanding of pain, it's logical that people would expect non-science-based approaches and that they would consequently be used. It's logical that people would not accept active movement-based approaches because moving hurts and hurt equals damage. It's logical that people receiving evidence-based treatment may feel unheard or not well cared for because they don't understand how pain works. Without a contemporary understanding of pain, non-evidence-based and risky biomedical practices and interventions such as opioids make perfect sense. They will be expected and used, leading to suboptimal management of persistent pain. There are also financial incentives in the healthcare system that are not conducive to improved pain management. Financial incentives for low-value care, for example. Low-value care means treatments with little or no benefit to patients, or that carry risks of harm that exceed their benefits. Interventions that are discouraged in evidence-based guidelines, such as medications, imaging, and surgeries, are widely available and often publicly funded, whereas recommended treatments such as active and psychological therapies and treatments addressing the central nervous system are not. Policymakers with misconceptions about pain may be more likely to direct resources towards non-evidence-based pathways. Both the public and healthcare professionals would benefit from a better understanding of pain and treatment based on current scientific understanding. Evidence-based care will only be embraced when these misconceptions are countered. And that will require a concerted effort of all of the stakeholders, including patients, clinicians, professional organizations, funders, decision makers, healthcare system administrators, and educational institutions. Public health messaging can change the narrative around pain to promote evidence-based care, improve medical management, and to empower people to actively engage in self-management strategies confidently. Through education and policy changes, we can shift public expectations away from low-value care that targets structural pathologies with limited evidence of efficacy and high cost, toward whole person care. I want to tell you about an example of a successful public health campaign that took place in Victoria, Australia in 1997-98 that aimed to shift public attitudes about back pain and to improve medical management of back pain and reduce disability and related costs. And because there's good evidence that fear and beliefs about activity, about avoiding activity, contribute to back pain and disability, the campaign provided evidence-based messages about low back pain not being dangerous and the importance of staying active and at work, of exercising, and of avoiding rest for prolonged periods. And one of the main messages of the campaign was, there's a lot you can do to help yourself. And this emphasized a shift of responsibility to the individual. a shift of control to the individual, and that is associated with better outcomes. The campaign consisted of TV, radio, and print ads, billboards, publicity articles, posters, workplace visits, seminars, and it resulted in a 15% decrease in worker compensation claims in the state. It also resulted in improved back pain beliefs and improvements in disability and medical management among the general population and also by general practitioners. Clearly, persistent pain is a high priority public health issue requiring public health-based solutions with healthy notions of pain. We need to address the growing prevalence of pain and disability, the disparities in treatment of vulnerable populations, and the need for pain education. Remember that pain protects, but persistent pain overprotects. But modern pain science provides us with a better understanding of what to do about it. Public health initiatives can change beliefs, can discourage unhealthy behaviors, and encourage helpful behaviors. Together, pain science and public health provide hope. And I hope that this presentation has given you hope and gotten you excited for the possibility of changes in ways that we can change the narrative to improve the lives of millions of people. And we'll answer some questions now if you have questions, but if you have questions that you'd like to ask me in the future or talk more about pain, here's my contact that will be in the recording.
Thank you so much, Mari. That was awesome. I really learned a lot. And it really has me thinking. Questions. We have time for a few questions if folks would like to do so. I can actually, I'll go. So I'm a social worker by training, Mari. I'm in the School of Public Health now. You know, my profession is really, in a large way, focused on social justice. And it seems to me that there is a connection with what you're putting forth and social justice. And I'm thinking all kinds of things like, big pharma and the establishment. And anyways, is that in your thinking at all that this is a justice issue?
I would agree with you. It is a social justice issue as people who are most in need of persistent pain care are often the ones who are least likely to receive it. There is differential treatment often in the provision of treatments for persistent pain. And a lot of these factors, these social determinants of health, are drivers of pain as well. So they're disproportionately impacted.
Thank you.
Thank you for drawing that out.
Others? Claire?
Hi, yes, thank you so much for that presentation. I have a question for you about the timing for those evidence-based interventions. Does it make a difference at what stage a person is in terms of their chronic pain, in terms of how long they've been in chronic pain for?
Thanks. That's a really interesting question. And yes, time periods matter, but also we can consider that some of these changes that occur in persistent pain, the changes that occur in the nervous system, many of them begin right from the timing of an initial injury, but they can become more ingrained, more prolonged as pain persists. And changes do occur as pain persists. More nervous system changes occur, there are changes in the brain. In terms of education, for example, if you were going to talk about a person who just has an acute injury versus a person who's been experiencing pain for a year, it would likely differ how you would educate that person. But you could also consider that the person with that acute pain injury is in a context, has beliefs, has emotional experiences, has a social environment that's affecting them, that's affecting their sense of threat and the level of just how ramped up their nervous system is, and the likelihood of a transition towards chronic pain. So in addressing people with acute injuries, for example, back pain, we might want to determine with pain assessments, what's the risk of this person transitioning to chronic pain? And so we might want to address that person with more education. As pain progresses and these more entrenched, that's what I was looking for, these more entrenched changes occur in the nervous system, there are other treatments that may be more useful, like the mirror therapy, that you're not going to use for an acute injury, of course. Is that answer somewhat your question?
Yes, thank you so much.
So it depends on the person, it depends on the injury, and that's part of the art of tailoring education to the individual and addressing persistent pain and identifying all of the factors that are contributing to the person's pain experience. Are they relevant to address for a person with acute injury? They may be, they may not be necessarily. An athlete may have many contextual factors that are very influential in their pain experience and that trajectory over time. So you might want to address those. Thanks for that question.
Anyone else, please put a question in the chat or unmute and just ask your question.
And Jim, can you hear me? Oh, good. Thank you so much for that presentation. It was really interesting. And I have kind of a personal dog in the race because of chronic back pain and bulging discs with nerve impingement and things like that. And so I listened very carefully to what you shared. I was wondering if you could talk a little bit about any kind of population health findings that are starting to emerge in states where the use of medical marijuana has been made normal or has been normalized as a way of treating pain. It's my understanding that there are a lot of people in our community that have a lot of concerns about how many marijuana dispensaries we have here and what the long-term effect that might have on a whole number of things, I suppose. And so I was just wondering how legitimate that approach to treating pain is considered to be, and if there are any sort of population health level findings about those states in which that's a common or legalized and normalized approach.
Yeah, that's a very interesting question. Thank you. As my understanding is that there are not enough long-term studies available yet to know about the long-term effects of marijuana and its usefulness and its negative effects. It's likely that there's a great deal of placebo effect involved in marijuana. But aside from short-term, as far as I know, it produces a positive feeling. So that contributes to not feeling so bad. So that's changing the experience around with, in that painful experience. But there are just not enough studies yet to show its effectiveness or the long-term hazards involved in that, as far as I know. But I'd be happy to look into that some more and find out and get back to you.
Thank you. We do have time probably for one more question, and we have one in the chat along with the comment. Tara says, thank you for this important presentation. If we could receive citations for journal articles that you have written and or recommended, that would be greatly appreciated. And then I have a second question. So, and Tara, we'd be happy to help with that. I'll see with Patrick about what we can do along those lines. And also we have Mari's email address. Do you have any information on the overlap of this information with genetic syndromes, such as Ehlers-Danlos syndrome? And I apologize, I probably said that incorrectly.
genetics is a factor in the pain system sensitivity. Genetics can contribute to sensitivity. And there are studies that show that genetic changes, most of them are, of course, animal studies, do show that genetics are a factor. And there are human studies that show that genetics are a factor as well. I don't know, I don't recall right now specifically anything about, I'm never good at pronouncing either Ehlers-Danlos syndrome. But genetics is a factor, yes.
If I may, I'm sorry I had to be off camera. I had to take care of something. I didn't want to be a distraction. So thank you so much again. It's such important information. I wish it had all been implemented at that systemic level 100 years ago. So I think I was just asking because EDS, we can pretend to not pronounce it Ehlers-Danlos or Ehlers-Danlos syndrome. It does have this idea of mast cell activation and how to handle pain. And it's often misdiagnosed. So people end up having, like, I've had about 30 orthopedic surgeries in my life and blah, blah, blah. So I was just wondering if there was anything specific in there for genetic syndromes where there is, like, basically not the highest amount of issue with it, but a great deal is pain.
Yeah.
And so
Yeah, thank you. I don't want to imply that things in the body, the biological factors, are unimportant. They are important, but our understanding of pain now is that there are other things that influence pain as well. And biological factors may not even be the most important ones. And if we can think about how we might experience a certain body part's pain differently in different situations, that can shed some light on how that can change, even though it's the same injury. And for someone who has gone through multiple medical procedures, such as yourself, there's a lot of stress and likely trauma involved in that.
Yeah.
And that likely contributes to the pain experience as well. So there's an initiating event or condition, but then there's all the context around it. And much can be done to influence that pain experience in a person who does have a genetic condition or who has some sort of condition that provokes pain. I think that's one of the key things that we can take away, is that there's a lot we can do that is not just medical interventions.
absolutely.
That may have risks, and adverse effects.
And is there a starting to grow or form of psychologists or licensed clinical social workers who believe
Yes.
that this is the way? And
Yes.
again, could that information be included, please?
Yes, it's not just me. It's not just me. There is an understanding worldwide now, and that it takes a team often to address a pain problem of psychologist, nurse, doctor, physical therapist, mind-body practitioner, and support for self-management.
Thank you so much. I hope I didn't take too much time at the end.
You're perfect. We're at 2:59, just perfect. We like to start and end on time to respect everyone's busy schedules. However, Mari has been gracious enough to share her email. And if anyone ever has any questions and you can't get a hold of our speakers, track down Patrick or myself, and we're happy to make connections. So we've got another presentation coming next week. Hope to see you all. There'll be some information on that coming out soon. And again, thank you very much, Mari. This is an excellent presentation and new information for many of us, I'm sure. So
thank you all. Thank you for this opportunity. Thank you. Thank you for questions.